Good afternoon. Welcome to the Lower Cape Fear's YWCA Talk on Health. This is a conversation done in collaboration with the Lower Cape Fear YWCA and the Wilmington chapter of Delta Sigma Theta Incorporated. Thank you for joining us today. I am Dr. Lekeshia Jarrett, and I am a family medicine physician for Wilmington Health. I will begin by giving the YWCA's land acknowledgement. The YWCA of Lower Cape Fear serves the people located within the Lower Cape Fear region. This land once thrived with life from indigenous peoples, known today as the Cape Fear Indians and the Waccamaw Siouan Indian people. Living in established settlements along the Cape Fear River and Lake Waccamaw, along with many other established sites in the region. We need to protect and honor the history of these places. Indigenous peoples are not relics of the past. They are here, continuing to demonstrate their talents and gifts amidst a backdrop of ongoing colonialism and oppression. They are worth celebrating. We hope our land acknowledgement statement will inspire others to stand with us in solidarity with Native nations. Thank you. Today's topic is I'm Every Woman, the many aspects of women's health. Little did we know when we decided to have this conversation that President Biden and Vice President Harris would decide to designate this as Black Maternal Health Week. We are so excited to be able to have a conversation about women's health at a time like this. Today, my experts are Dr. Lolita Bryant, Dr. Imelda Odibo, and Dr. Leanne Garner. I'm going to give them an opportunity to introduce themselves and tell about their expertise. You can begin, Dr. Bryant.
Well, good afternoon. I am Lolita Bryant, and I currently work at Novant New Hanover Regional Medical Center as a patient safety coordinator. I've been with the organization for almost 38 years. I also work at the University of North Carolina at Wilmington in the RN to BSN program, nursing program, where I teach there, as well as the Cape Fear Community College Associate Degree program. My area of expertise is in labor and delivery, and my research focus is in perinatal mood disorders, and that covers the pregnancy period throughout the first year after they have their baby. The importance of women's health is really special to me. This week has been Black Maternal Health Week, and we've had a phenomenal, impactful speakers all week long talking about this very important topic. Also today on women's health, I feel like we as been blessed with the beautiful body, mind, and spirit, and we have to definitely take care of our vessels as well. So I'm grateful to be here today. Thank you for having me.
Dr. Odibo, could you please introduce yourself?
Sure. My name is Imelda Odibo. I am an obstetrician and gynecologist with a specialty in maternal fetal medicine. So I take care of pregnant women who have complications that could be because of their baby or because of the mom herself. Maybe the mom has medical issues that complicate the pregnancy or surgical issues. I practice here at New Hanover Regional Medical Center, well, now Novant Health. I've been here for 6 years, and our practice here is Atlantic Fetal Medicine. So we basically devote our efforts to taking care of mothers from all walks of life, or colors, or races, wherever they are coming from, and to make sure that we have good maternal and fetal outcomes.
Dr. Garner, can you please introduce yourself?
Yes, thank you. Very happy to be here with all of you. So I'm Leanne Garner. I'm from Duplin County, which is about an hour north of here, and I am a just general OBGYN, which means I do pretty much anything that you can think of that would be within the umbrella of obstetrics and gynecology. So we operate, we deliver babies, we see patients on the continuum in the office throughout life. I currently practice at Glen Meade Center for Women's Health, which is affiliated with Novant Health New Hanover Regional Medical Center, and been here about 4 years now. And whenever we have high-risk pregnancy patients, we enlist Dr. Odibo and all of her expertise. So we work together, we get to work together quite a bit, and I'm very, very happy to have her in the community.
Thank you very much. So we'll get started here. I'm just going to have a quick follow-up question to start by asking Dr. Odibo if she could name some particular health problems that you take care of as a maternal fetal medicine doctor.
Sure. So for babies, so we take care of if during the pregnancy a baby is found to have an abnormality. So we do have some babies who have heart defects where their heart does not pump well, or their kidneys, or any part of the body that there's a problem with the way it formed. We help to take care of those babies during pregnancy. And of course, once the baby is born, we kind of nicely hand them over to our neonatologist to take over from there. And as far as maternal problems go, we take care of women who have high blood pressure issues, diabetes, autoimmune disorders, any medical issues at all, even women who have had surgical issues that may also complicate their pregnancies.
Okay, thank you very much. Well, let's start from the beginning. The first question that we had to come in was, why does it seem like more Black women have fibroids?
So I deal with fibroids almost on a daily basis in my practice. So it may seem that way because in America, there is a slightly higher incidence of fibroids in Black women when compared to white women or Hispanic women. It's not a huge difference though. I will say we see it. I see it in all races all the time, and it's extremely prevalent. It's present in about 50% of African-American women, a little less in Caucasian women, but it's extremely common, and we see it all the time.
Can you discuss some different treatment options for fibroids?
Sure. There are so many, honestly, it can be a little overwhelming sometimes, I think, for patients. The main thing is to know how many fibroids, where they're located. We determine this typically with an ultrasound. So if we suspect you have fibroids, that's one of the very first things that we do. And that will kind of help guide us in treatment options and things that we can discuss. There's really kind of 3 buckets of treatment options that I usually will offer patients depending on, of course, their medical history and surgical history. One bucket is some medications that you can take actually to reduce bleeding that are not hormonal. Then there's the hormonal bucket, which is probably the most overwhelming and the largest. That can go anywhere from a birth control pill to an IUD, actually. Those are awesome for everything, but they're great for fibroid bleeding as well. Then there's some hormone suppressors and some of the bigger medications that we reserve for patients with severe disease or larger fibroids. And then there's many surgical options ranging from very minor procedures, which we can do as an outpatient surgery, to myomectomies, where we remove the fibroids, which is a much bigger surgery with a difficult recovery. And then, of course, there's hysterectomy, and there's various types of hysterectomy, and there's so many ways that we do those these days. There's 5 different ways to remove a uterus, but that's reserved again for women done with childbearing and women who have pretty significant disease. There are also some newer technologies where we can actually reduce blood flow to the uterus by kind of plugging up the uterine arteries. It's called uterine artery embolization, and even some technology using ultrasonic waves to kind of reduce fibroids. So when I said it's overwhelming, it can be quite overwhelming. And we really try to cater it to the patient and what her goals are in the future.
And I actually have a question from the audience already, which is, how do you know that fibroids are not cancerous, or what are the chances of a fibroid being cancerous?
Yeah, that's a great question. So they're rarely cancerous, thankfully, because again, they're so common. It would be awful if they were commonly, or commonly known to cause cancer. So fibroids that typically tend to be, malignant or have cancer potential, are ones that grow very rapidly. So if you notice like a huge increase in uterine size or ultrasound, or ultrasound size when we're measuring them, then that would be very concerning. Or also just, ridiculous bleeding. Sometimes you'll notice a huge change in bleeding or pain, and those can be indications or indicators.
Thank you very much.
May I add that
Yes.
From the obstetric aspect of it, I do have a lot of patients who never even knew they had fibroids. So most patients are going to be asymptomatic. You're going to be living your normal life. You're not even going to know that you have fibroids. Sometimes we just see them incidentally. They come in for pregnancy and we now find out they have fibroids and they tend to get worried about it. And I always reassure them that if they did not have any symptoms before, excessive bleeding and things like that, which are typically what brings people to doctors like Dr. Garner to evaluate them in the first place, that they are likely to do well. We do have some people with very big fibroids that are on the closer to the inside of the uterus, and that may affect pregnancy sometimes, but that's not a lot of people. So most women are going to do fine with their pregnancies.
Thank you. So following up on our discussion about Black Maternal Health Week, the next question is, how does race and class affect pregnancy outcomes?
Wow, I can speak on this for sure. So we know that this is not ambiguous at all, that minority women tend to have worse outcomes in pregnancy. The rate of, and we're talking about things ranging from maternal death, which is of course the worst outcome we can ever think of, to the even smaller complications like sexually transmitted diseases in pregnancy. The rate of preterm birth in the United States is anywhere about maybe 10 to 12%. It's about 17% in Black women. Black women are more than 1.5 times more likely to die during pregnancy or due to issues related to the immediate, pregnancy and post pregnancy period. So race is a huge factor in whether a woman walks out of the hospital healthy and good, or whether the woman has complicating issues even during the pregnancy itself and outside of the pregnancy. And we know that it has nothing to do with how much money you have or how much education you have. They have tried to piece all that into it to see if that will make a difference. But studies have shown that no matter how rich you are, regardless of your socioeconomic status, as a Black woman, that your outcome is much worse than that of your white counterparts, which makes us wonder if race itself is the reason. And that's because people have postulated that it may be because of all the inbuilt structural discriminations that exist that may be fueling this, and also interpersonal racism that happens between, and I know providers don't want to hear this, but we feel like there is interpersonal racism that exists. And also even within ourselves as Black women, when we are told so many times there's something wrong with you, you have worse outcome, people tend to internalize these things, and it all kind of leads up to chronic stress, which we know is one of the fuels for adverse pregnancy outcomes.
And I would like to add to that, if I can, Dr. Odibo.
Thank you.
There is a lot of systemic racism, which we know is a public health crisis that harms not only African American people, but everyone. And we need to find a way that we can show the health equity areas that we need to work on, basically with that, because we know that I think would help with the healthcare providers if they would know the culture dynamics and how it impacts the healthcare that they provide, by knowing the difference in what African American women needs are, and as well as other needs. And we want to talk about the women of color, because it seems like those numbers are really high when they come in to have babies, because their outcomes are much different. A lot of the moms feel like they're not being heard when they come in. They can come in and they complain of headache or blurred vision, and they're sent home and possibly not seen the way they need to be seen. Whereas if they'd taken a little bit more time with those moms, the outcome would have been so much better. So we really need to do better when it comes to providing care for our African-American moms, as well as our people of color, to make sure they feel like they're being heard. And I think what it's going to take is, because there's a lack of understanding the culture in itself, I think it's going to take a system where we have this interdisciplinary education for our healthcare providers to make a difference in our outcomes for our moms and babies, so we can have decrease the morbidity and mortality that happens when it comes to Black maternal health.
And I would just quickly like to add too, it's not just maternal health that's affected, it's neonatal mortality is higher in Black babies, which is just, I mean, it's overwhelming really, just, you know, as a white woman in this field to hear that. And I do think it starts at the top. And I think we need to do a better job of training our healthcare providers to recognize implicit bias and try to prevent, you know, that from affecting their care.
I should stop putting myself on mute. I'm just, thank you all so much for all of that information. I'm going to add that, you know, we've done some other talks, and last month, our talk was on nutrition in the Black community and food deserts and things like that. And I just think all of that plays into maternal health and just health in general. So thank you all very much. When should a person see a doctor when they have a positive pregnancy test at home?
Okay, I can speak to this one for a minute. I want to encourage all women to, ideally, we would love for everyone to plan their pregnancies, but we know that that's not always possible. But if you can, we want you to plan ahead and start taking your prenatal vitamins prior to actually getting pregnant, a few months before you actually get pregnant. But once you have a positive pregnancy test at home, we typically, I know Dr. Garner, for your patients, they typically come to see you around 8 weeks pregnant. When you're about, I would say, 2 months in, we want you to have seen your obstetrician at that point in time, just because we know that starting care late, again, predisposes us to these adverse pregnancy outcomes that we want to prevent. So when you do get that positive pregnancy test, you should be trying to get in with your doctor within a month or 2 after that. And of course, you need to start taking your prenatal vitamins right away. I mentioned before that ideally, you know, for women, for me personally, women who have pre-existing medical issues like diabetes and hypertension, we do want you to have a certain hemoglobin A1C even before you become pregnant. So that's why it's even very important that you show up early so that we can see you and make sure that all ducks are in a row and that we're creating a wonderful environment for your baby.
And especially if you're on I'm sorry to interrupt. I was gonna say, especially if you're on medications that you're not sure about, you might even need to see us even sooner. Or if you have some serious health conditions, I mean, even maybe sooner than 8 weeks would be appropriate.
Can anyone speak on diet, exercise, smoking, and alcohol during pregnancy, and when those changes should occur?
Definitely. Again, I think it still goes back to maybe it's best to plan a pregnancy, but we know that that's a little bit too much to ask for sometimes. But once you have a positive pregnancy test, you're supposed to stop any alcohol use at that point. We would, of course, prefer, there is no safe level of alcohol in pregnancy, let me say that. So even one sip of wine, we do not advocate for. And alcohol is the most common cause of mental retardation. So we do not want people to there's fetal alcohol syndrome. So we don't want people to drink alcohol during pregnancy. So you need to stop that immediately once you get a positive pregnancy test. As far as smoking goes, we prefer that women of childbearing age not smoke at all, if possible. Smoking is associated with, in fact, smoking is the #1 modifiable risk factor for preterm delivery. So it's the one thing, you know, a lot of people have preterm delivery and we don't know why they deliver their babies early and why these babies end up in the NICU with brain bleeds and all of that. But smoking is the one thing that we can modify. But if you already do smoke, once you become pregnant, we actually talk to you about it during every prenatal visit. We encourage you to, you know, start cutting down a little bit at a time, and it's never easy, right? So you take small steps all the way, because we know that if you were smoking 1 pack a day and you cut down to 2 or 3 cigarettes a day, that has that also impacts a lot of benefits. The less you smoke, we do see the benefits in pregnancy.
Dr. Bryant, would you like to add anything to that conversation?
But just making sure that you, to follow what she said, making sure that you see your nutritionist and making sure that any health issues that you possibly have, make sure that you're going to your visits and asking the correct questions that you need to ask at that particular time or during your visits. A lot of times our moms are not sure of what some of the side effects or the issues that they have with these the smoking and that type thing. So we really need to educate them a little bit more on some of the things that they need to be aware of and using while they're pregnant. A lot of times that smoking one is one of the biggest ones that they have an issue with. But if we can hone in on making sure that we give them a list during their first visit of things that need to decrease and their use as they begin their pregnancy visits, I think we're going to be able to make a difference in the outcomes of our babies and their moms during their pregnancy and postpartum.
Can I quickly add, and you'd asked about diet and exercise, just a few words about these. So as far as diet goes, once you do become pregnant, we want you to watch what you're eating. We want people to drink more water and cut out on these sweetened beverages and soda and things like that. They're not healthy for us at all. So water, we advocate for you to drink at least 8 glasses of water a day. That's about 64 ounces. And we want, as far as diet goes, we want you to cut down on carbohydrates. We worry about gestational diabetes in pregnancy. We do want you to cut down on carbohydrates, eat a little bit more proteins and vegetables and things like that. Exercise, we don't want you to go register at a gym or anything like that. Please, nothing complicated. If you can just take a walk for 30 minutes a day, that is acceptable to us, and get like maybe a total of 150 minutes of exercise a week. So walking 30 minutes, 5 days a week will help you to achieve that. Or even if it's just on weekends that you have time, maybe you can take a longer walk 2 or 3 days a week.
And I would like to add to
I'm
that.
so glad. Oh, go ahead.
Sorry. I would just like to add to that piece of with the exercise. Sometimes African-American moms have more issues with blood pressure issues as well. And if they do that walk, it's going to help with that, because that can be a chronic issue that will spill over into their pregnancy area, which may increase their chances of getting something as a preeclampsia. And that's what you'll see. A lot of times those outcomes can be bad for moms and babies. So the exercise is really going to be big with that if they continue to exercise, plus decrease their fried foods while they're pregnant as well, and continue that water and vegetable intake as well.
I was just going to say that I'm glad you said that, because, you know, everyone always says you're eating for 2. And And I would tease people and say, the baby is only going to weigh 8 pounds, probably, around that. So if you're eating for 2 and you gain 50 pounds, you're not going to lose 50 pounds when you deliver. So, I have another question from the audience, which was about diet drinks. Does anyone have anything to say about using diet drinks during pregnancy?
I guess try not to use them if you can. If you're completely addicted, like most Americans, I mean, in moderation, like maybe 1 a day. We prefer the non-caffeinated varieties, of course. But if you're like me and you just really like that little fizzy taste, they make so many excellent little flavored waters these days. That's how I get my couple liters a day that I try to drink when I'm at the office. There's all kinds of fun brands, so try that.
That's a good option. Thank you. The next question is, why do women develop incontinence as they get older?
Another great topic that I discuss daily at the office, because it's that common, honestly. And I think a lot of women feel ashamed and they just were really nervous to bring it up. But I encourage you, please, definitely, this is something we can fix. So incontinence, I explain it to my patients like this, think of your bladder as a toddler. If you do not feed your toddler what he or she needs, healthy things, if you do not train your toddler to behave in a certain way, then it's going to be unruly and terrible. And your bladder is the same way. I think we abuse our bladders throughout life, and the older we are, the more issues we're going to have with it, right?
And doctors, of course, don't do that.
Yes. Oh, we're awful. We're horrible. We don't pee for 8 hours a day seeing patients. That's the worst thing you can do. Nurses too. I mean, as anyone in healthcare. But caffeine, alcohol, any kind of acidic foods, these are very irritating to the bladder, of course. So those are things that we do with time, and then just poor bladder habits that we just discussed basically can cause more urgency and urgent continence. Obviously too, childbirth, the more pregnancies you have can cause you to have some pelvic floor issues, and that can cause stress urinary incontinence, which is more along the lines of if I'm coughing, sneezing, moving, jumping, running, blah, 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 then you're having some leakage and some trouble with that too. So yeah, it's sometimes it's things you can't avoid. If you have a 9-pound baby, you can't help it, but some things that you can prevent.
To help with that pelvic floor being strengthening too, I think we suggest the Kegel exercises where we do the muscles, try to strengthen those muscles down there after you have that baby. Can be hard, but if you would practice doing those Kegel exercises where you're tightening up and loosening up, that kind of help you with that incontinence too, as opposed to not being able to hold your water when you need to.
Right. And you can take it to the next level too, which so another thing that I literally prescribe every day is pelvic floor physical therapy. We use it for everything. It's like an IUD. I use that for everything, and I use this for everything. They're amazing. But yeah, it can help with all types of incontinence and other issues as well.
And I just wanted
in the audience to share that pelvic floor physical therapy is a woman's best friend. So.
Agree.
Those exercises are great. They really are.
Right. I'm sorry, Dr. Odibo.
Sorry, I just wanted to add too that I was, when I was training, in obstetrics, high-risk pregnancies, we didn't talk about incontinence a whole lot. And then when I was studying for my boards, I saw this whole section talking about prevention of incontinence. And basically all the studies that were done on Kegel exercises in pregnancy, and actually how many times a day a woman should do it and the number of repetitions. And I was shocked. So from time to time, of course, I don't remember to tell my patients all the time, but from time to time when they do ask me about it and when they do complain, I go whip out that study and, send them a message about how many times, and how many rounds and repetitions that they should do. So the Kegels definitely somewhere to start.
Thank you. Is there ever a need for surgical treatment of incontinence? And can you speak to that a little bit, Dr. Garner?
Sure. So surgical treatment mainly helps with stress incontinence, which is due to like a structural abnormality, typically of the pelvic floor. So, and we reserve it for women who fail pelvic floor physical therapy, or we even have like a vaginal laser now that rejuvenates collagen. So if those things are not working for you, and then that would be a good option. There are several types of sling procedures that we perform, or even Botox injections, believe it or not. Botox is another thing that can be used for everything, you know. So yeah, and the sling surgeries are very safe. They're outpatient. They do involve mesh, and mesh has gotten a very bad name thanks to lots of lovely commercials. But that's the different type of mesh. This mesh is generally, accepted in the medical community, and has very low risk. That the commercials are about vaginal mesh, which we don't even use anymore.
Does anyone have anything else to add? We're going to move on to infertility now. It seems like the rates of infertility are increasing. Does anyone have any thoughts about whether that is really true, or whether we're just talking about it more, and treatments? We'll discuss treatments after that.
It seems as if the rates are increasing, but I would think it's because of a number of issues, based on, and one of them is women having children later on in life, period. Women are more educated these days. They have a little bit more independence. They have a little bit more flexibility and a choice as to when to start their families. Unlike before, once you're 17 or 18, I don't know how it was, but people are expected to just get married and, have babies. So women had their babies in their, late teens, early 20s, and they were done. My mom had 10 children, and I went, how on earth did you have 10 children? But I'm glad she did, because I'm the last of 10. So if not, I wouldn't be here. But these days, oh my goodness, you have to pay me $1 billion for me to have 10 children, right? Because I had to figure out my education first and do all of that. So we think women are basically putting off having children until later on, and that's contributing to, that's part of the issue. And then there are other contributors to infertility too, including lifestyle choices, smoking, alcohol use, illicit drug use, STDs. Those things also contribute to infertility, and also just medical issues. It seems as if there's more obesity, people are having more obesity related issues like diabetes and hypertension and things like that. So I think that these are some of the contributing factors.
If you have irregular menstrual cycles, is it more difficult to get pregnant?
Absolutely. That's a sign something's wrong, right? Our periods are like it's like a gynecologist vital sign, it's like your blood pressure is to Dr. Jarrett, So when they're irregular, it means you're not ovulating regularly, or possibly at all. We all know you must ovulate in order to conceive. So yes.
What are some options for women who are career women, like all of us are, who might not be ready to conceive until later? Are there any options that can help them to plan for that?
Before I speak on options, can I, for a moment, I had to remind myself to say that infertility is not only just female infertility. Okay,
Thank you
there's
very
also
much.
male infertility, and I honestly, I grew up in Nigeria where women were blamed for everything. If you didn't have a child, it was the woman's fault. Marriages, your husband can pretty much say, I don't want to marry you anymore. I need to marry another wife. Nobody ever pointed a finger at the man. We want to say that a good number, if not, Leanne, maybe close to half of
it's 50% in my practice and in general. Yes.
Exactly. It's male related infertility, but then we're going to go back to our women. Treatments you asked, Dr. Jarrett?
Yes.
Okay. So it depends on the cause of the infertility. So of course we have, for the woman, gynecologically could be just a problem with ovulation. The most important thing is if you are 30, if you're less than 35 and you've tried for a year and you haven't gotten pregnant, it's time to come pay Dr. Garner a visit pretty much. And if you are more than 35 and you've been trying for 6 months, it's time to come in. Please don't waste too much time. The longer you wait, the more difficult the process will become. So you have to come in, you need to be evaluated, you need to be examined. They do a lot of blood work related to your hormonal, your hormones. Ultrasound is done to check your uterus to see if there are any issues there. And then they kind of start honing in on what could be possibly the cause of your infertility. If they are thinking that it's an ovulation issue, we have medications like Clomid, Letrozole, Femara, there are a number of medications that you can be given to help you ovulate. And the doctor can give you this medication for you to ovulate, and you can still have timed intercourse. You can still have intercourse. You don't need to do, anything more fancy at that point. You can just have Clomid and timed intercourse. And sometimes they may step it up where you would actually need what we call intrauterine insemination. So it just depends. If you have any structural issues in your uterus, they may have to plan surgery. If you have blockage in your tubes, that's kind of treated a little bit differently also. So I would say that it does depend on the reason, on the suspected reason for your inability to get pregnant.
Thank you.
I would just like to add one thing that Clomid is not just for women. So like Dr. Odibo said, I work up infertility all day and I order semen analysis as well. And so about 50% of the time, that's the issue. It's not, on the female side. So, I have lots of urologists that I send, the patients to, and they will prescribe Clomid to actually boost sperm counts and motility and other things. And they check, hormones in the men to see if there's need replacement testosterone or whatever. So yeah, there's a lot that can be done on both sides.
Well, I learned something today. I did not know that Clomid was used to treat male infertility.
Yep.
Also, thank you. So we talked a lot about pregnancy, and I want to move to the postpartum period. It was very surprising for me. No one prepared me for the postpartum period. Lots of surprising things happened to my body that I wasn't expecting. So, but sometimes postpartum depression happens too. And I think Dr. Bryant does a lot of work with postpartum depression. How do you know if you have postpartum depression?
But first of all, a lot of times it may not show up as depression in the beginning. A lot of times it starts with postpartum blues, where moms, it's a new baby, you're going to have those tearful moments in the beginning, and that's normal. But if it goes past 2 weeks, you may want to have someone, talk with someone about that. So you can be evaluated, call your OB and have them talk with you about that, and maybe have them do a screening of you with the Edinburgh tool. They can ask you those questions, what you've been feeling. And if you get a certain score on that Edinburgh tool, then we may need to give you some type of counselor or have someone, a therapist, talk to you at some point. But you go it can happen from postpartum blues to depression. And then sometimes those moms may have anxiety or either obsessive compulsive disorder, or that can cause issues as well. So we want to make sure we know that 1 in 9 moms will have some type of postpartum depression. And we know that 1 in 3 moms of African Americans possibly have postpartum depression, and sometimes it's just totally overlooked. But I think we have to decrease that stigma. And when you're feeling those, as those crying spells, reach out. We have a wonderful Postpartum Support International, which is an international organization, and their mission is to make sure that moms are well. And that is postpartum.net. We have wonderful Zoom meetings for moms that may be feeling depressed. Actually, I will say that I am one of the Postpartum Support International coordinators for New Hanover County and Brunswick counties, where they reach out to me if mom is feeling like she's blue or wanting to do something to hurt herself. They will call me, and I will outreach with resources to provide her someone she can speak with, and then possibly from there they will get her a psychotherapist or someone to talk to. But when you're feeling blue and don't want to, sad times, don't want to eat, you lose your appetite, possibly don't want anything to do with your baby, don't want to hold the baby, family members will see that. And if that's happening, we want to reach out to possibly get mom some help for that, so it doesn't go any further. Because if it goes from postpartum depression to, you can go from perinatal blues to postpartum depression, and then it can go to psychosis. And that's where you're going to have issues where mom can hurt herself, her baby, or entire family. So it's really something that we need to decrease that stigma and let moms know it is okay. If you're not feeling okay, it's okay not to be okay. Let somebody know we're here, you're not alone, and we're here to help.
Are there things that increase your risk of having postpartum mental health issues?
If you have a history of postpartum depression, or had a family history of postpartum depression, or even had perinatal mood disorders with your first pregnancy, that is going to definitely increase your risk. So you would hope that your OB would take a look at that and possibly screen you in the beginning to make sure that that was a history, you had a history with that you would not have that with this recurring pregnancy. So it is definitely something you want to take a look at. If you've had a history, that you're more likely to have the postpartum depression once again if you had it with your first pregnancy.
Thank you.
But also, I would add any high-risk pregnancies, stressful pregnancies, pregnancies where, or a history of infertility when you've worked so hard to get to this point, and now you're like, oh my gosh, what do I do with this baby and these hormones? Babies that have to go to the NICU, those moms tend to be more depressed for lots of reasons, obviously. But yeah, there's lots of risk factors. Unfortunately, that's why we see it so commonly and treat it.
And that was my area with the NICU moms. I was a NICU mom. I had twin girls at 29 weeks, and my girls weighed 2.1 and 2.5 and stayed in the NICU for almost 3 months. And so those moms are anywhere from 37 to 70% more likely to have perinatal mood disorders because of the increased anxiety of what's going to happen to my baby, the length of the time the baby has to stay there, financial issues that they may have because they don't have the monies to probably take care of that particular bill. But so my research was in where I actually trained the nurses on postpartum depression, so they can be aware of those signs and symptoms of those moms in the neonatal unit, where they can outskirt those resources and collaborate with a social worker to make sure they get the resources they need and will not further on have more postpartum depression or issues post going home with those babies. So it's really important, and it can be very stressful, especially with the NICU moms, when they don't know if they have the finances to continue to take care of the baby while they're there and then post-delivery. So I am so glad that we're talking about this today, because we have to decrease the stigma of postpartum depression and work with those moms to get them the resources that they need.
I just wanted to add, this is so important. We try at obstetricians, we screen all of our patients at the very beginning of every pregnancy. And if they do have a history, we actually make a note of checking on their mood at every single visit. We ask them, how are you feeling, what's going on, and things like that. And I do remind patients all the time also that because some of them go, I'm doing fine, I'm good. And I remind them that postpartum, there are a lot of hormonal changes also. There is lack of sleep, which is a field for worsening mental health issues also. And now the fact that you have a new baby to take care of, it's all, it's like all the perfect storm. And we do encourage them to seek help and make sure that they do let their doctors know if any issues arise.
And I would like to add to that, we have to think of our dads also, because dads can have postpartum depression. We have to be careful of that, because our moms get stressed, and when moms are not doing their part, then dads have to kind of take over. It can be stressful for them. So we've had calls where we had dads that had postpartum depression and have to get help for them as well. So we need to make sure we're continuing to encourage those moms to speak up when they're feeling down to get help. And we're here to make sure that they get that for sure.
Thank you. We have another question from the audience, which is going to move us into a different direction, which is there a way to tell if you have endometriosis?
Sounds like a good one for me, so I'll start. So another thing that I talk about almost daily. So this is great. This is definitely my jam. So yes, if you have very painful cycles, typically your pain will start before the cycle begins, or if you have painful intercourse, those are kind of the two hallmarks of endometriosis. Also, having a family history can put you at a higher risk. Or having a lot of surgeries, especially gynecologic surgeries in the past, can put you at a little bit higher risk. There's no way to know you have endometriosis without doing surgery. So that's a common misconception. You cannot diagnose endometriosis without actually performing surgery and seeing the implants in the abdomen and biopsying them. Certainly there are patients I'm very suspicious, and I'm 99% sure this is going to be positive, but we can't know without doing surgery.
Okay. We're going to also talk about ovarian cancer for a bit. How do we screen for ovarian cancer, or how do you screen for ovarian cancer?
Unfortunately, we don't have adequate screening for ovarian cancer. And there's a lot of research being done on this currently because it's such a fast growing cancer. Typically, when you come see me once a year, you see your primary care doctor once a year. That's not enough really, because this typically grows much faster than that. So there's not anything that we can do on an annual basis that will be, ensure that you don't have ovarian cancer. I mean, certainly we ask questions when you come you look for symptoms of ovarian cancer. We do a pelvic exam where we can hopefully feel a mass. However, as you know, the pelvis can hide large masses. This is why some women have fibroids that are the size of a grapefruit and had no idea because they just couldn't tell. So this, same thing happens with ovarian cancer. It has to be pretty advanced for us to be able to feel it in the office and for patients to have symptoms. I've read there are some really interesting new things coming down the pipe potentially. I hope it all pans out about Pap smears being able to detect a certain protein that's common with ovarian cancer. Right now, Pap smears do not test for ovarian cancer. I cannot say this enough times. A lot of patients think that the Pap smear does more than it does. It only is looking for cervical cancer. That is it. Doesn't look for uterus, doesn't look for uterine cancer or ovarian cancer. So we just don't have good screening tools.
What are the symptoms of ovarian cancer that you spoke of that we might see in patients?
So they're very vague, which is why this is so difficult. So, I mean, it could easily be, oh, I ate something and made me feel bad, so it could be bloating, it can be nausea, it can be changes in your bowel habits, it could be constipation or diarrhea. It can be early satiety, which means you cannot eat as much as you used to without feeling full and kind of bloated and just off. Certainly you can have pain, but that's actually not very common. It has to be pretty advanced to have pain. So what I tell patients is when we're discussing this, and it's certainly more common in postmenopausal women, if you feel you're having any of these symptoms, give it a few days, a week or two. If it doesn't resolve, there could be something going on. It's not a virus. It's not something you ate at that point, and we should definitely look into it.
Thank you. So our next questions are about breast cancer. When should women receive their first mammogram? And does it matter if someone in their family has had breast cancer?
So for just any woman without a family history or other risk factors, we should start screening at age 40, which is a change in the last few years. It was 35, now it's 40. And then annual screenings after that, meaning every year mammogram. And so if you have a family history, this is something you need to discuss with your primary care doctor or gynecologist. At our practice, we have a screening form where actually we write down all of your cancer history in your family and determine your risk, and actually a percentage risk. And if it's over a certain amount, we certainly, opt for earlier screening, more frequent screening, different types of screening. But, the simple answer would be, let's say your mother had breast cancer at age 42. Well, then we would definitely want to start screening you much sooner than 40. So we would likely at least offer mammograms starting at 32. But mammograms are not great for younger women to detect breast cancer. So there's lots of other screening modalities, that we would use, like MRIs and ultrasound at that point.
And I would like to add to that, the best thing we can do is always check ourselves. We do like self breast exam in the shower, or somewhere where we can actually lay down flat and put our arm behind our back and do our own exam for lumps or anything like that, to check for those types of lumps, and then notify your physician. And don't wait. Some people are scared. I've heard people are scared once they feel a lump, not wanting to go to their physician, but we encourage you to continue to go to your physician if you're feeling that, so you can get a thorough exam and they can help you with that.
And one more thing I would like to add, you reminded me, so that the biggest thing that we can do as women to prevent breast cancer is just lead a healthy lifestyle, like no smoking, keep a normal, healthy body weight, exercise, minimize drinking. A lot of women put a lot of emphasis on their family history, but only 10% of breast cancer is genetic. So 90% is the way we're living our lives. But also, of course, you could be the picture of health and it could still happen. So I'm not saying that's the only thing, but we can certainly minimize our risk by, altering our lifestyle.
Is there any need for genetic testing if someone in your family had breast cancer?
Yes, and that's the screening tool that we use in my office, and I'm sure many other offices do the same thing. So there's, certain kind of red flags that trigger us to definitely, consider testing. So that would be a first-degree relative who had breast cancer before menopause, so before the age of around 50. Any aggressive, like really aggressive triple negative or both breast, bilateral breast cancers in the family are kind of a red flag. Male breast cancer, believe it or not, that happens. Men can get breast cancer, and that's a huge red flag for a possible genetic, condition in the family. And so yeah.
So I have questions from the audience again. One is, when I had my hysterectomy, I was in my early 30s. My doctor advised me to keep my healthy ovaries. Was this a bad decision because of ovarian cancer?
No, your doctor's so smart. That's great. So kind of back in the day, when they were doing hysterectomies, like our moms and grandmas, they took ovaries, and I'm so sad they did that. Because we now know, number one, surgical menopause is horrible. It's worse than normal menopause, meaning when we take the ovaries, you have no hormones, and the symptoms can be very bad. But also, taking the ovaries too early may also have some cardiovascular risk that we did not realize. Obviously, the physicians 30 years ago didn't know this, or they wouldn't have been doing it. But so it can put you at a higher risk of cardiovascular disease if your ovaries are removed too early. The risk of ovarian cancer is nothing compared to the risk of heart attack and cardiovascular disease in women. It's the number one killer in women.
So 2 more questions from the audience. How often should women over 50 get Pap smears, and what are the signs and symptoms of cervical cancer?
So boy, these guidelines change all the time. It seems like every year you come in and I've got a new guideline for you. So currently the guidelines are to start at age 21 and do Pap smears about every 3 years. I say about because certainly there are different circumstances where they should be shorter or longer. And so those are the current guidelines, and they change a lot. I will say, definitely check with your insurance. many insurance companies are no longer covering annual Pap smears, even if that's what you want. So if you don't know that, it's important. We get a lot of calls back about this because they're getting bills for Pap smears because insurance isn't covering. And then the second part of your question, cervical cancer doesn't have a lot of symptoms either, unfortunately. And so, you know, bleeding after intercourse or irregular bleeding in between your periods. And I cannot say this enough. I have a poster right behind this computer in my exam room about the Gardasil vaccine that prevents cancer. It is the only vaccine we have that prevents cancer. Make sure your daughters, your sons, make sure you get it. You can get it all the way up to age 46 now.
Thank you. Thank you. I know that Pap smears have done a lot to help us with cervical cancer screening. That has been a wonderful thing. So I'm interested in seeing how the guidelines continue to change. I often get parents who bring their 18-year-olds in to get a Pap smear. And you said the age was 21. So is that with or without sexual activity?
Good question. So that is with or without, it doesn't matter. It doesn't matter when you began being sexually active. If it's 15, if it's 21, it doesn't matter. We still start at 21. And that's because HPV is so prevalent. In other words, it's so common, right? So like 90% of us will have, HPV at some point because it's so easy to transmit, and you only have to have sex one time with one partner. So it's very, very common. And so thankfully, though, our bodies typically do fight it off. It's a virus. And so by waiting until 21, we prevent a lot of false positives and a lot of procedures that were being done on young women that can affect your fertility actually later in life.
Okay, thank you guys so much. I could talk to you for another couple of hours, but we're running out of time. Could you all please just give a 1-minute final word that you would like to share with the community, starting with Dr. Bryant?
I would say this has been a really good session, and I want to just focus on the maternal health. Black Maternal Health Week has really been awesome this week, and we want to make sure that we not only use the platforms to do it weekly, but to continue it throughout the year and on where we can make these changes and decrease the infant mortality and morbidity and mortality for moms and as baby as well. And these type of platforms where we're doing what we can to eliminate racism with the YWCA, we need to continue to have these events and these talks where we can educate the entire community. And anytime that I can do what I do to make a difference in the community, I'm happy to do that. And thank you so much for having me today.
Thank you so much for coming. Dr. Odibo?
This was wonderful. Thank you so much for having us. And just to all providers out there, I know we all go out every day wanting to do the best for our patients on a daily basis. And in the spirit of maternal health, also maternal and infant health, I do appeal to everyone to no longer be colorblind. I want you to actually see color every time a Black woman walks into your office, and I want you to make sure that you are treating that woman the same way that you would treat anybody else that comes to your office, because this does impact on maternal morbidity and mortality.
Thank you. Dr. Garner?
So I guess I would close with just advocate for yourself. In other words, if you feel you're not being heard, if you feel you're not being treated fairly or properly, you've got to speak out, and you've got to bring up some of these very difficult topics, that some of which we've discussed today. Go to the doctor. Just go to the doctor, get your checkups.
All right. Well, thank you all so much. I look forward to having you back on again at some point.
Thank you.
Bye-bye.
Thank you. Bye.